एंड में मैंने ये प्रेजेंटेशन रखी है।
बिल्कुल बिल्कुल
जी।
आपके नाम के साथ SI लिखा है, दैट मीन्स सितारे इम्तियाज।
जी सितारा इम्तियाज।
माशाल्लाह माशाल्लाह, we've got such great people on this forum.
अस्सलाम वालेकुम ब्रिगेडियर साहब, मैं प्रोफेसर बिल्किस।
अच्छा अच्छा मैम, आप मैम किस जगह होती हैं?
सर मैं KE में हूँ, चेयरपर्सन डिपार्टमेंट ऑफ मेडिसिन एंड प्रोफेसर ऑफ।
अच्छा 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 अच्छा। वो मैं लाहौर में रहा हूँ फ्रॉम 2016 टिल 19।
अच्छा अच्छा अच्छा।
तो वो आपकी वो हेमाटोलॉजी की वो हैं डॉक्टर साहब, उनसे मेरा इंटरेक्शन रहता था, बल्कि एक दो मैंने प्रेजेंटेशंस भी किंग एडवर्ड्स में की हुई हैं। जबरदस्त। तो आप कब की ग्रेजुएट हैं?
सर मैं 1997 की FJ की ग्रेजुएट हूँ, और मैं 2000 में थी, बट 2016 से 2019 में KE में नहीं थी।
अच्छा
I went to Bahrain and then when I came back to Pakistan, तो फिर मैं सियालकोट, फिर गुजरांवाला, फिर फातिमा जिन्ना and then to King Edward।
अच्छा अच्छा अच्छा। वो आपकी
ये ब्रिगेडियर साहब भी पहले लाहौर रहे हैं मैडम, और अब माशाल्लाह अब कमांडेंट हैं अपना AFIT का, और ये लाहौर इनने काफी टाइम गुजारा है ब्रिगेडियर साहब ने।
जी जी बिल्कुल बिल्कुल बिल्कुल।
माशाल्लाह, वो यही बता रहे थे सर।
तो सर आप किधर जा रहे हैं इस वक्त?
सैर करने सर, अकेले अकेले जा रहे हैं।
ठीक ठीक
सर ये राना रिजॉर्ट जा रहे हैं सर, आपने मॉस्पेल ली हुई है?
जी मैडम, आज आपने
आऊज़ु बिल्लाहि मिनश शैतानिर रजीम, बिस्मिल्लाहिर रहमानिर रहीम। अम्मन हुवा क़ानितुन आनाअल लैलि साजिदन व قائما يحذر الآخرة ويرجو رحمة ربه قل هل يستوي الذين يعلمون والذين لا يعلمون إنما يتذكر أولو الألباب۔ ترجمہ: بھلا مشرک اچھا ہے یا وہ جو رات کے وقتوں میں زمین پر پیشانی رکھ کر اور کھڑے ہو کر عبادت کرتا اور آخرت سے ڈرتا اور اپنے پروردگار کی رحمت سے امید رکھتا ہے۔ کہو بھلا جو علم رکھتے ہیں اور جو نہیں رکھتے دونوں برابر ہو سکتے ہیں؟ میں دوبارہ کہتا ہوں، کہو بھلا جو علم رکھتے ہیں اور جو نہیں رکھتے دونوں برابر ہو سکتے ہیں، اور نصیحت تو وہی پکڑتے ہیں جو عقل مند ہے۔ صدق اللہ العظیم۔
جزاک اللہ خیر۔
جزاک اللہ۔
جی پروفیسر سلما کوندی، اوور ٹو یو۔
جی، on this forum I thank Dr. Mulazim for arranging another wonderful speaker who's Brigadier Naeem Saab. Welcome Brigadier Naeem Saab. ہم آپ کی اس ویبینار سے مستفید ہوں گے، اور اللہ پاک اس ڈینگی کے مرض سے اور کرونا کے مرض سے ہم سب کو اپنی حفظ و امان میں رکھے اور ان کا خاتمہ کرے، کیونکہ پورا ملک اور پوری دنیا پریشان ہے۔ ڈینگی کی وجہ سے ہم پریشان ہیں اور کرونا کی وجہ سے سارا عالم پریشان ہے۔ بہرحال پاکستان کے ڈاکٹرز نے جتنا کچھ کیا ہے، hats off to them and salute to them. And we have some very good people amongst us who are very, very well versed with both these diseases, اور ان کے کنٹرول میں ان کا بہت بڑی contribution ہے، and I really, really admire them. So I also thank the panelist, Professor Nuzhar Mushahid Saiba. I think she's joined us, and Balkis Saiba, because ye hamare Rui Raman hai, and Qazi Saab, and obviously Rashid Saab. Now I give it over to Brigadier Naeem Saab.
Bismillah. Bismillahirrahmanirrahim.
Sorry, Naeem साहब का तारुफ नहीं किया. Sorry, I'm so sorry for that. Naeem साहब हमारे AFIP में commandant हैं, and he is the head of the Department of Pathology, and he's done wonders. मैं भी देख रही थी, सितारे इम्तियाज भी इनको मिला है. Obviously इनकी बहुत जबरदस्त service है in the field of pathology. हमारा one of the brains of Pakistan in the field of physiology. Welcome, Naeem Saab, and now over to you. Thank you.
Thank you very much. Bismillah ar-Rahman ar-Rahim. I'm thankful to Dr. Mulazim and all of you for inviting me to give a talk on dengue fever. Though I feel that all of you must be knowing more than me, but I'll try my best that I update you on the latest developments regarding dengue fever and the management regarding platelet transfusions. In the beginning, I will give a brief overview of short overview of dengue hemorrhagic fever, and then I'll come over to the talk concerning the transfusion of platelets in this disease. World Health Organization has classified dengue as the most important mosquito-borne viral disease in the world. And dengue is spread all over the world, and according to the latest data, it is endemic in more than 125 countries of the world. So almost 75% of the world's population is exposed to dengue disease. This dramatic expansion of dengue in the recent past has been attributed to the urbanization and the population explosion. And that has taken its effect in Pakistan also. So very briefly, dengue is a viral disease that is transmitted to the humans by Aedes aegypti, and in some cases by another Aedes species, that is Albopictus. Dengue virus is an RNA virus. It has got 4 major serotypes, and various genotypes also occur. So in Pakistan, just for academic purpose, genotype 2 and 3 are more prevalent. Very briefly regarding the pathophysiology of the disease, when the dengue virus enters after the bite of mosquito, it binds to the Langerhans cells, and it enters through binding between the viral protein and membrane proteins on the Langerhans cells. The dendritic cells move to the area which are nearest to the lymph nodes. The virus genome is translated in a membrane-bound vesicle on the cell's endoplasmic reticulum. And ultimately, the immature virus particles are transported to the Golgi apparatus and mature into new viruses. This aspect is, I think, important for the students who might be hearing this presentation. In response to the dengue virus, various antibodies are generated, and some bind closely to the viral proteins and some target them for phagocytosis. The dengue virus genome encodes 3 structured proteins. I wouldn't go into detail. The important proteins are usually 7 non-structural proteins, which include NSA1, 2, and so on. So non-structural protein 1, which is also known as NSA1, is important for its diagnosis. The manifestations of the disease like COVID-19 is due to the immune responses with the production of cytokines and chemokines. Activation of T lymphocytes takes place, and in all, they disturb the hemopoietic system. The release of cytokines are the major reasons for the plasma leakage and the circulatory insufficiency. Moreover, there is an increase in apoptosis and endothelial dysfunction. So that was very briefly the pathogenesis. The bleeding manifestations of dengue fever are caused, they are threefold by vasculopathy.
Excuse me, जरा सा slides आप आगे बढ़ा दें. If these are on the
Ma'am,
slides.
मैं थोड़ा सा preamble दे के then I'll be coming over to the slides.
Okay. Thank you. Thank you.
I just thought that if I give a preamble of the pathogenesis and dengue fever, that would be more appropriate to understand the management in case of thrombocytopenia.
Great. Thank you. Thank you.
So the bleeding manifestations include vasculopathy, thrombocytopenia, platelet dysfunction, and coagulopathy. Then there are different phases of the disease, acute febrile stage, in which diagnostically the prothrombin time and thromboplaster time is increased. Now, regarding platelet transfusions, there the most important thing is that there is no clear guideline for the management of thrombocytopenia and platelets, whether it be WHO or CDC or whatever. But the consensus is that platelet transfusions are recommended to be given in patients who have a trigger. In a case of bleeding patient, 20 or less than 20, and in a non-bleeding patient, the trigger is 10,000 per microliter. Pardon? The trigger is 20,000 per microliter platelets in case of a bleeding patient, and in a non-bleeding patient, the trigger is 10,000 per microliter. The British Committee for Standardization in Hematology Guidelines agrees to these triggers. And the very important thing to realize is that if we don't follow these triggers and we give platelets prophylactically, they can cause more harm than good in such patients. And mainly in such a patient, fluid overload occurs. And according to the standard guidelines, if you see, according to the CDC or WHO, or the British Committee for Standardization, there is absolutely no place for prophylactic platelet transfusions. So regarding the need for packed red cells, if there is a massive hemorrhage and there is a loss of blood, that is overt blood, of more than 10% of the total blood volume, you can resort to packed cell transfusion, and the replacement volume should be around 10 ml per kg body weight. Fresh frozen plasma is given in patients suffering for dengue fever for the management of coagulopathy who are bleeding. This is very briefly regarding transfusion of blood components in dengue fever. And then coming to whether such patients should be transfused with random donor platelets or single donor platelets. Obviously, the single donor platelets have got advantage over random donor platelets. The disadvantage is basically the cost for us to manufacture a single bag of single donor platelet. It costs us about 30,000 rupees. While a random donor platelet costs us about 900 rupees. So the potential advantages of single donor platelets are reduction of infectious complications, transfusion reactions are decreased, there is ease of having leukodepletion, there is a reduction in transfusion frequency of platelets if you resort to single donor platelets. Then there is prevention of alloimmunization. and enhancement of platelet quality is there. So if the question arises, which one is the better option for giving platelets, obviously single donor platelets are better. Then I will come to the presentation very briefly. Presentation Lagain ji. As I said before, that these CDC guidelines clearly dictate that we don't give platelet transfusions for a low platelet count, meaning that if one person has a count of around 40 to 50,000, there is no need for giving platelet transfusions. Again, I repeat that in a bleeding patient, the cutoff is 20,000 per microliter, and in a non-bleeding patient, it is 10,000 platelets per microliter. The platelet transfusions do not decrease the risk of significant bleeding, but if they are given against the guidelines, they may lead to the fluid overload and prolonged hospitalization. If we come to WHO guidelines, the prophylactic platelet transfusions for severe thrombocytopenia in otherwise hemodynamically stable patients have not been shown to be effective and are not necessary. You know, in the present day circumstances where everybody is asking for platelet transfusion and they are not sticking to guidelines, we must resort and stick to these WHO guidelines. Then if we search literature again, if the marked thrombocytopenia is a criteria for hemorrhagic fever, as I've told you before, what are the cutoff values? Now, these transfusions may be during the acute phase, may be done according in the acute phase or in the initial phases. Factors that contribute to bleeding, as I've said before, include thrombocytopenia, then there is coagulopathy and vascular leakage. In general, the data does not support a role of prophylactic transfusions in a patient with severe thrombocytopenia in the absence of active bleeding. Then, according to NIH USA Advisory for Prevention and Control of Dengue Fevers, again, they agree that platelet transfusions are not effective for preventing or controlling hemorrhage, but may be warranted in severe thrombocytopenia, where severe thrombocytopenia is defined to be less than 10,000 per cubic liter. So very briefly, that is end of my. I'm sorry, there is some interference. Okay, so this is in short all briefly. The packed cell transfusions are advised to be given in severe hemorrhage. FFP in dengue fever is mostly resorted to for the treatment of coagulopathy, and the cutoff for platelet transfusions I've discussed before. Thank you very much. And if you have any questions, I would be happy to answer.
Now I will request Professor Nuzhar. Professor Nuzhar is also, she was also commandant of the AFIT, and she is now panelist. If Madam Nuzhar, you are
thank you. Thank you, Professor Mulazim, for inviting me here as a panelist. Yes, before Naeem took over, I was commanding AFIT. This is definitely a very relevant topic these days, no doubt about it. Since I don't know background of attendees, so actually I exactly would not know that what is the most relevant thing to discuss. However, I believe that probably since the invitation went from the pathology side, it is probably most of the pathologists would be attending it. And most of the pathologists attending would be called upon in a role of a blood banker. क्योंकि हमें पता है पैथोलॉजी वाले और हेमेटोलॉजी और ये ब्लड बैंकिंग जो है वो यही सारे लोग जहाँ पे प्रॉपर हो रही है वो कर रहे हैं। अगर मैक्रो लेवल पे देखे जाए तो इस बड़े चैलेंज को हम डील नहीं कर सकते विदाउट अ होलिस्टिक अप्रोच which should involve all stakeholders, and that starts from a policy based policy decisions which are based on data, that is epidemiology, and then implementation through healthcare delivery system जो भी है। इसमें बहुत बड़ा रोल है आई थिंक प्रोफेशनल सोसाइटीज का। वी आर ऑल्सो फ्रॉम अ प्लेटफॉर्म ऑफ प्रोफेशनल सोसाइटी हम एड्रेस कर रहे हैं विच इज़ पैप, बट PSH और जितनी भी मेडिकल सोसाइटीज़ हैं, प्रोफेशनल सोसाइटीज़ हैं, उनका बहुत बड़ा रोल है। अनफॉर्चुनेटली हम वो रोल प्ले नहीं करते। कम अज़ कम हम अपने सर्कमस्टांसेस में एक पोजीशन स्टेटमेंट भी लें, पोजीशन लें भी, हमारी बात जो है वो नॉलेज बेस्ड होगी तो बहुत उसका इम्पैक्ट भी होगा। तो हमें यूनाइटेड किस्म का जो है इसके ऊपर जो है वो अप्रोच लेनी चाहिए। एंड सिमिलरली इसमें स्टेक होल्डर्स जो पेशेंट्स हैं वो भी बहुत बड़े स्टेक होल्डर्स हैं और उनका भी बड़ा इम्पोर्टेंट रोल है। अभी कंट्री में जो मुझे देखने में मिलता है वो ये है कि इट्स अ नॉन स्टैंडर्डाइज मैनेजमेंट जो कि विम्स के ऊपर चल रही होती है, कंसेंसस बेस्ड नहीं होती, एविडेंस बेस्ड बिल्कुल भी नहीं होती, गाइडलाइन ड्रिवन नहीं होती। It is ad hoc, it is driven by whims and individual approaches to the things, और individual approaches vary करती हैं depending upon the knowledge। और फिर उसके ऊपर जो है जो भी अगर कंसेंसस है अगर हम बना नहीं पाते और अगर जो गवर्नमेंट की हैं उसको इम्प्लीमेंट भी नहीं कर पाते। मतलब पंजाब ने बड़ी अच्छी एडवाइजरीज दी है, उनकी एडवाइजरी ग्रुप है और उसके ऊपर वो रेगुलरली मीटिंग करते हैं और अपनी वो जो है वो गाइडलाइंस भेजते हैं, लेकिन जो एक्चुअली ग्राउंड पे प्रैक्टिस देखने को हमें वो मिलती नहीं है। इट्स नॉट गाइडलाइन ड्रिवन। तो इसमें अगर हम PAP के प्लेटफॉर्म से बात कर रहे हैं तो आई थिंक वी नीड टू हैव अ जॉइंट कंसेंसस पोजीशन स्टेटमेंट और जो बेहतरी के लिए जाए। अब आई कमिंग टू द पॉइंट कि जी ट्रांसफ्यूजन के हवाले से क्या होता है। हमारी जनरल टेंडेंसी है सब जगह पे जो मुझे देखने को मिलती है वो ये है कि वी ट्रीट रिपोर्ट्स, we treat labs, we are not treating patient। इधर थ्रोम्बोसाइटोपेनिया आया, 7 पैनिक हुआ, 7 प्लेटलेट ट्रांसफ्यूजन के ऊपर चले गए, नॉट लुकिंग इनटू के जो है वो एक्चुअली उसकी हेल्पफुल क्या होना है, उसका नुकसान होता है उल्टा। तो वो जो है लैब की बेसिस के ऊपर ट्रीट हो रही होती है, नॉन गाइडलाइन नॉन एविडेंस बेस्ड ड्रिवन होती है। नईम ने पॉइंट आउट कर ली है चीजें, उस पर में बड़ी रेलेवेंट बात ये है कि प्लेटलेट हमने कब देना है, जुडिशियसली देना चाहिए। इट्स अ एक्सपेंसिव ट्रीटमेंट, इट्स अ हाई रिस्क ट्रीटमेंट। तो जो बहुत सारे केसेस हैं उसमें तो रिक्वायर्ड ही नहीं है इफ वी स्टॉप ट्रीटिंग द लैब रिपोर्ट्स। फिर उसके बाद बात आ जाती है कि जी ये जो है वो मेगा यूनिट प्लेटलेट्स हमारी वोकेबलरी में तो है नहीं ब्लड बैंकर्स की, मगर ये है कि वो क्लिनिशियंस की वोकेबलरी में ये बड़ा इनग्रेन्ड है। इन्होंने प्रॉब्ली दे एज्यूम के जी ये मेगा यूनिट प्लेटलेट्स जो है ये सिंगल डोनर प्लेटलेट्स हैं। सिंगल डोनर प्लेटलेट जो है वेरी एक्सपेंसिव है, अवेलेबिलिटी का इशू है, और इस किस्म के सर्कमस्टांसेस में उसकी यूटिलिटी को बहुत ज़्यादा एडवांटेज नहीं देती। दैट्स माय व्यू पॉइंट बेस्ड ऑन सम रीज़न। और वो रीज़न क्या है कि दुनिया भी रिजॉर्ट कर गई है क्योंकि सिंगल डोनर प्लेटलेट की सबसे बड़ी इंडिकेशन ये है कि वो HLA मैच्ड होना चाहिए, प्लेटलेट एंटीजन मैच्ड होना चाहिए। ना तो हमारे पास डोनर की जो है वो रजिस्ट्रीज हैं, ना हम HLA मैचिंग कर सकते हैं, बल्कि जिस काम के लिए हमने करना है कि रिफ्रैक्ट्री है प्लेटलेट, रिफ्रैक्ट्रीनेस है प्लेटलेट को, वो भी हम डेमोन्स्ट्रेट या डॉक्यूमेंट नहीं कर पाते। तो इसलिए इस एक्सपेंसिव ट्रीटमेंट को रिजॉर्ट करने की बजाय द मोर एमिकेबल वे टू डू इज कि हम इनको पूल करके ल्यूको रिड्यूस करें। दुनिया भी यही कर रही है। सो द प्लेटलेट्स विच आर ल्यूको रिड्यूस्ड एंड pooled, they become equivalent to single donor platelet and it reduces the cost to half. Well, ये तो hardcore blood banking की बात है, but as far as dengue management is concerned, उसमें 2 जगह पे सपोर्ट का रोल आता है, और वो क्या है, यहाँ तो शॉक सिंड्रोम में, यहाँ जो है हेमरेजिक डेंगी जो फीवर हेमरेजिक मैनिफेस्टेशंस के साथ होता है, उसमें एवरीबडी नोज के जी फ्लूइड मैनेजमेंट बहुत साइंटिफिकली उसको करने की ज़रूरत होती है, जो कि एमरजेंसी केयर या बेड साइड पे केयर पे क्लिनिशियन मेडिसिन वाले या एमरजेंसी केयर वाले या जो भी केयर कर रहा है उसकी डोमेन में फॉल करती है। और उनको क्लोज कम्युनिकेशन में रहना है पैथोलॉजी के साथ, बिकॉज इट्स अ हेमाटोक्रिट ड्रिवन मैनेजमेंट। اگر ہیماٹوکریٹ فال کر رہا ہے تو بلڈ ٹرانسفیوژن کی ریکوائرمنٹ ہے. اگر بلڈ ہیماٹوکریٹ جو ہے وہ انکریز کر رہا ہے تو کولائڈ یا کرسٹلائڈ کی مینجمنٹ کی ضرورت ہے. اور اگر ہیماٹوکریٹ فال کر رہا ہے اور somebody is suspecting کہ بلیڈنگ ہو رہی ہے تو پھر اس وقت جو ہے وہ 2 آپشنز ہیں, یا ہول بلڈ ٹرانسفیوژن کریں یا پیکڈ سیل دیں. ہول بلڈ ٹرانسفیوژن کرنے کا مطلب یہ ہوتا ہے کہ اس میں پلازما بھی ہے اور اس میں ریڈ سیلز بھی ہیں, اور ریڈ سیل کا کام ہے آکسیجن کیری کرنا, کیرنگ کیپیسٹی, اور پلازما کا کام ہے کولائڈ اور اسموٹک پریشر پرووائڈ کرنا. تو یہ تو وہ جو شاک لائک سنڈروم ہے جس میں ہیماٹوکریٹ فال کر رہا ہوتا ہے اس میں یہ انڈیکیٹڈ ہوتا ہے. اسی کے دوران اگر آپ نے ڈاکیومنٹ کر لی ہے کسی نے کہ ڈی آئی سی بھی ہو رہا ہے تو وہاں پہ رول بنتا ہے کہ جی دین یو میں لک انٹو کہ پلیٹلیٹ ٹرانسفیوژن کی ضرورت ہے. ادروائز نان ڈی آئی سی کنڈیشن میں یا بہت میسو بلیڈ اگر نہیں ہو رہی تو اس میں پلیٹلیٹ کی انڈیکیشن نہیں ہے. یہ جو تھریش ہولڈز ہیں یہ آربیٹریلی اس لیے ڈیفائن کیے جاتے ہیں کہ آپ کچھ پیرامیٹرز ڈیفائن کرنا چاہتے ہیں اپنی پریکٹس کو ایک تھوڑا سا یونیفارم کرنے کے لیے, ورنہ ادروائز اٹ ہیز ٹو ویری فرام کیس ٹو کیس. اس میں کلوز لیزون کی ضرورت ہے بلڈ بینک کے ساتھ اور لیب کے ساتھ, تاکہ لیب کے جو پیرامیٹرز ہے اس کی بیسس کے اوپر آپ جو ہے وہ تیار ہوں اور بلڈ بینکنگ اور بلڈ ٹرانسفیوژن سروسز جو ہیں آپ کو اس وقت وہ پرووائڈ کر سکیں. سو یوزلی جہاں پہ میں بیٹھی ہوں میری تو اپروچ یہ ہے, اور آبویسلی اٹس اے پریونٹیبل ڈیزیز, اور اس کے اوپر جیسے میں نے کہا پیتھولوجسٹ کا بہت امپورٹنٹ رول ہے لیب کے ڈائگنوسس کے حساب سے بھی اور بلڈ ٹرانسفیوژن سپورٹ کے حساب سے بھی. اس میں یونائٹڈ کام ہونا چاہیے, ہمارے سرکمسٹانسز کے حساب سے ہونا چاہیے, گائیڈ لائن ڈریون ہونا چاہیے, کنسنسس کے ساتھ ہونا چاہیے, سارے اسٹیک ہولڈرز کو انوالو ہونا چاہیے تاکہ ہم اپنی کنٹری میں کچھ ڈفرینس بنا سکیں. تھینک یو ویری مچ.
If anybody has any questions.
Yes, may I ask Dr. Rashid Ahmed? اچھا یہ ڈاکٹر راشد محمود بول رہا ہوں. یہ تو کنفرم ہے کہ جو انڈوتھیلیل ڈسفنکشن ہے اس کی وجہ سے فلوئڈ لیکیج ہو رہی ہے, اور بلیڈنگ جو ہے وہ اس میں پلیٹلیٹ ڈیفیشنسی کے علاوہ انڈوتھیلیل کا کافی رول ہے. تو کیا کوئی ایسی چیزیں جو کہ انڈوتھیلیم کو اسٹیبلائز کریں, لائک اسٹیٹینز آر سیڈ ٹو بی ٹو امپروو انڈوتھیلیل فنکشن, یا کوئی اور ایسی ڈرگ کوئی ہے جو کہ یا ویزو کنسٹرکٹرز کا کوئی رول ہے کہ اگر کم بلڈ جائے گا تو ایسی کوئی چیز ہے ابھی کوئی ریسرچ میں ہے؟ یا ایک جگہ کہیں پڑھا تھا کہ یہ اومیگا فیٹی ایسڈ ہیں اس پہ ورک ہو رہا ہے کہ دے کین اسٹیبلائز انڈوتھیلیم, تو ایسی کوئی چیز کہیں پہ آ رہی ہے؟ یہ میں نے کہیں دیکھا تھا کہ اس پہ کام کر رہے ہیں. اینی باڈی
اس پہ جی جی میم.
نہیں سر یو گو ہیڈ. پھر میں
جی یہ جس طرح سر نے بات کی یہ ساری ایکسپیریمنٹل تھراپیز ہیں, اور اس میں ابھی کوئی ایسا وہ کوئی ان کا کوئی پروون رول یا ان کی ایکٹیو کوئی انوالومنٹ نہیں ہے مینجمنٹ میں. اور یہ جتنی بھی تھراپیز جیسے آپ نے بتایا یہ ساری ایکسپیریمنٹل ہیں. اس میں جس طرح بریگیڈیئر نصرت نے کہا کہ جی اس میں یو ہیو ٹو لک آن دی کنڈیشن آف دا پیشنٹ اینڈ ہاؤ دا پیشنٹ از پروگریسنگ. And obviously there is no gold standard, or there is no drug to treat dengue fever. You have to treat the symptoms, and basically the role of the transfusion is that if as we have discussed before, if there is some coagulopathy, you resort to the use of fresh frozen plasma. And if there is severe hemorrhage and the hematocrit, as Brigadier Nuzhar said before, is falling, you may resort to red cell transfusion. And you have to see the clinical condition of the patient. And again, I would repeat that if the patient is bleeding, only then you should be using platelets. And in the present circumstances, as we are seeing nowadays, that even if the platelet count is around 50 or 40,000 and patient is not bleeding, there is a hype to transfuse prophylactic transfusions, platelet transfusions, and it causes more harm to the patient. And this message should be spread across the all the doctors fraternity, that the misuse of platelets which is being carried on should not be there. Thank you.
आप बताएंगे कुछ
Thank you.
I
experiments
would,
बताएं।
with permission of Professor Salma, can I add something?
Yes, sure, sure.
It was a wonderful talk. Thank you so much, Dr. Naeem and Dr. Nuzhar. Your comments were very, very valuable and very highly weighted. It's just that I felt that we should just clarify, because I believe this forum is also attended by students and postgraduate residents and medical officers. We just need to define the definition of dengue a little more clear. I'm also a member of the advisory board, which Professor Nuzhar just referred to, DAG, that is the Dengue Expert Advisory Group. And basically, the group was created back in 2011 when the Sri Lankan team came to help us in the first big epidemic of dengue we had in Pakistan. And it was created at that time, and following that, every year, the advisory board meets and twice a year, the guidelines are updated. We just need to know there are three categories of dengue patients. One, the undifferentiated fever, which is almost 90%, may go with minimal symptoms and may not be even noticed enough to be investigated. About 5 to 10% are those patients who have dengue fever or dengue hemorrhagic fever. And here we need to mention dengue fever can be with hemorrhage. And dengue hemorrhagic fever may be without hemorrhage. Dengue hemorrhagic fever refers to that type of dengue infection where there is, due to some previous infections and pre-existent antibodies in the system, the second, third, or fourth infections, that is secondary infection, results in an increase in the release of cytokines, which include tumor necrosis factor, endothelium-derived growth factor, which affects the endothelium, which Professor Rashid just referred to. It causes breakage in the intercellular junctions at the level of the endothelium, and there is leakage of plasma. That is dengue hemorrhagic fever. So dengue hemorrhagic fever can occur with platelets as high as 50,000 without any overt bleed. So this, please, everybody should, be able to categorize that it's a misnomer. The real, it's a wrong word. Dengue hemorrhagic fever, we call it dengue hemorrhagic fever, but it is actually plasma leak syndrome. Dengue fever can be with overt hemorrhage, but it may not be the critical leak syndrome. So I hope I have made myself clear. The second point is that the recent change in the guidelines has been that, yes, for diagnosis, we use the thrombocyte count, the platelet count of less than 100,000. But for admissions in a hospital, recently, in the March updated guidelines, it was 100,000. It has been reduced last month to 50,000. So if the count falls to less than 50,000 and the patient is not in the leaky phase, we may, sort of monitor the patient in between 50 to 100,000 and keep a watch on the hemorrhagic phase or the leaky phase, which I've just mentioned. The third point I want to mention is that why do the platelets fall? I think maybe I lost connection. Dr. Naeem was talking about it. Just to reiterate it, number one, because people think they leak out in the plasma. Day before yesterday, I came across a video which said that where there is plasma leakage, this is again a wrong myth, that where there's plasma leakage into the intercellular spaces, there's also leakage of the platelets. No, the platelets fall because of, number one, bone marrow suppression, which leads to initially leukopenia and then thrombocytopenia. Number two, there is destruction of the platelets in the circulation. And there has been studies, which are talking about anti-platelet antibodies, which are formed during the second phase of COVID, second infection of COVID. And the third reason for the fall in the platelets
is the damage to the endothelial cells, which leads to a picture which is almost parallel to the DIC. So there is consumptive coagulopathy. That is why when we are talking about a point in time where we are having patients with COVID and we have patients with dengue, and many times patients are coming with all the investigations of COVID, you will find out that the chest X-ray is clear, the COVID PCR is negative. On the other hand, D dimers are elevated with low platelet counts. So the reason for that is not that D dimer is elevated because of COVID, secondary to COVID, but because of consumptive coagulopathy. So this was a big confusion which we were coming across during the initial phases of the dengue epidemic, because we are still also going side by side with COVID. And this was leading to confusion. And the reason the D dimers are elevated is because of certain degree of consumptive coagulopathy. Somebody asked over here, and repeatedly it is being asked, when to give platelets, which Dr. Naeem has beautifully described. We can cure dengue with a count as low as 0. I repeat, with a count as low as 0 without giving platelet transfusion. So patient can come out of the critical leaky phase without platelet transfusion. The only indication is a bleed. And bleed, he has taught wonderfully the indicators of the bleed. Khoon ka patla khoon. So best is whole fresh blood in case of an overt bleed. The second indication you need to have a good backup is a pregnant lady who's in labor. So one of the indications, we talked about pregnancy and labor and dengue, I think 2 weeks from now on this very forum. It was beautifully described by Professor Tayyaba Wasim. A patient who is pregnant, you should have a backup of platelets of whole blood. Because anytime, the best is to delay the termination of pregnancy to as long as she is out of the leaky phase. But if she does go into labor and we are not able to stop it, then she might require a platelet transfusion. So these are the only few indications of giving platelet transfusion, as has been mentioned by Dr. Naeem. And one more thing, one more question which just crossed my eyes was the use of steroids. There is absolutely, as yet, no advocated use of steroids in thrombocytopenia, in coagulopathy, and in the endothelial dysfunction. The only use which is being it is not evidence-based as yet and has not been FDA approved is encephalitis and dengue expanded syndrome. Dengue expanded syndrome is that when besides dengue, there is involvement of other organs, which includes transaminitis, encephalitis, Guillain-Barré syndrome, transverse myelitis, myocarditis. So in such situations, you might require to give, if there is, for example, in GBS, if you are coming across high antibody titer, or you are coming across protein cell dissociation, the CVS, you can give a trial of steroids, but still that has not been fully approved by the FDA. So this is just all I have to say. Thank you so much. I hope I just came across a few questions, and I hope I answered them.
Thank you, Bilkis. That was beautifully explained. And so you have answered
Salma.
the question of Mahadev Harani. Now I would ask you all and Dr. Nuzhar and Dr. Naeem and Dr. Bilkis to answer this question from Wajir Rahman Saab. It is, what is the lower cutoff value for platelet transfusion in dengue patient with pre-existing CKD or CLD?
May I answer that? If Dr. Naeem can answer that, that would be
please do.
Yeah, because it's a clinical question. I would love to answer it. We have a high prevalence of CLD due to hepatitis B and C in Pakistan. And we have a high prevalence of CKD due to hypertensive renal disease and diabetes, besides other causes. There is, again, no distinct indication that itself is not a distinct indication for giving platelets. The indication is, again, an overt bleed or a pregnant lady whom you are planning to deliver, or any person whom you are going to go for any surgical procedure. One indication might be when you need to pass the double lumen catheter, and when you want to go for a hemodialysis, urgent hemodialysis in a CKD patient, and you want to pass a double lumen. For that, in case of a bleed, you might need to build up the platelet counts if they are less than 10,000. Otherwise, there are no distinct indications for giving. Yes, a CLD patient has an underlying esophageal or fundal varices or bleeding hemorrhoids. They have started to bleed. Yes, you can give platelets. But if they are not bleeding, which we are seeing in many patients having CLD on top of that, a dengue superinfection, and they are not bleeding, there's no indication for giving platelets prophylactically. As Dr. Naeem started, his first line on the first slide was, there is no prophylactic indication of giving platelets in dengue. Another thing is, many patients come to us, Dr. Saiba, ये ना मेरे तो platelets पहले कल आप कह रही हैं मैं ठीक हो रहा हूँ, कल थे 80, अब हो गए 40, अब हो गए 35, अब मैं क्या करूँ? So please, the answer is that the target is not to treat thrombocytopenia. The target is to, number one, monitor the leaky phase, which is जो बहुत अच्छी बताई गई है, अभी mention की है Dr. Nuzhar ने भी, which is mentioned by a fall in the pulse pressure, which is the difference between the systolic and the diastolic. Number two, a fall in the an increase in the capillary filling. Capillary refill time, ये जो मेरी उंगली है इसको मैं यूं दबाती हूँ, ये पेल हो जाती है, and it should come back to pink when I release it in less than 2 seconds. If this time is more than 5 seconds, that means that I am having a peripheral vascular compromise. That is an indication of a shock syndrome. And if the urine output has decreased, patient कह रहा है मैं पिए जा रहा हूँ पानी में, ड्रिप भी लग रही है, वो जीपी ने मुझे ड्रिप भी लगाई थी, लेकिन पेशाब मुझे नहीं आ रहा. So that would indicate that he's collecting the fluid into the third spaces, which Dr. Naeem mentioned that would be hazardous. आप fluid दिए जा रहे हैं, blood pressure बढ़े नहीं जा रहा, और ये बहुत, जब वो वापस सारा fluid from the third spaces into the circulation आएगा, patient would go in a state of overload. तो ये indicators clinical हैं, और pathological indicators जो डॉक्टर नुज़र बता चुकी हैं. Number one, rise in hematocrit baseline से 20%. So आज मेरा normal hematocrit 40 है, और मेरा कल 20% बनता है 8, तो कल मेरा 48 हो जाता है. Now your physician should be on your toes, on his toes or her toes. वो क्या करेगा, वो अब he knows कि next 48 hours leaky phase के हो सकते हैं. He is going to monitor again the same parameters, the pulse, the vitals, the pulse pressure, the intake output, and this should ideally be done 1 hourly for the next 48 hours. And then the very intricate fluid management with Dr. Nuzhar touched, that this is the time when you are going to measure, is a formula which is applied according to body weight, which you do not blindly give fluid. तो वो ये गलत है जो ड्रिपें लगा के हमारे पास ओवरलोड में मरीज आता है. That is a major cause of death in patients. Because वो ब्लड प्रेशर बढ़ नहीं रहा होता, वो एक ड्रिप लगती है, दूसरी ड्रिप लगती है, मरीज खुद कहता है मैंने ड्रिप पे लगाओ, तो उसमें that leads to overload when that. So it's a very finely calculated according to the output. In an average, I'll just mention a gross formula because majority of us are adult physicians here. The 48 hours quota. So after the patient enters into the leaky phase, the 48 hours quota is 4.8 liters, 4.8 liters over 48 hours. And it doesn't have to be 50%, 50%. So it can be more than 2.4 to 2.6 in the first 24 hours. And it can be less within the next. The thing is, we have to monitor according to the output, so that when all the fluid goes out back into the circulation, patient does not go into an overload. So that is the, the target of your therapy. ये जो मरीज और doctors panic में जाते हैं that platelet is falling, that it is bound to fall. and it is bound to recover. The only thing which is going to, trouble you is number one hematocrit, and the hematocrit. So hematocrit, when it increases, it indicates hemoconcentration due to plasma leak. Platelet count का fall होना, we have seen patients with mild dengue fever, platelet नीचे आए, मैंने बताया 10 तक भी आए, 5 तक भी आए, और एक मेरी पेशेंट थी जो कि 0 भी आए, म्यो हॉस्पिटल में 0 के साथ प्रेग्नेंट फीमेल थी, एंड माशाल्लाह शी रिकवर्ड. So please do not worry about the platelet count until there is a bleed, जो डॉक्टर नईम ने इंडिकेटर्स बताए हैं. ब्लीड है या कोई इलेक्टिव प्रोसीजर है या कोई इमरजेंसी प्रोसीजर है जो आपने करना है.
Thank you, Dr. Bilkis. I think it's a very freshening to know the clinician perspective. आप उन challenges को देख रहे होते हैं. From the support services, जैसे blood transfusion services हैं, they are very important. मैं जो लोग attend कर रहे हैं, उनकी consumption के लिए बता दूं कि यहाँ पे चूंकि ब्लड बैंकिंग का बहुत ज़्यादा डेप्थ में नॉलेज नहीं होता लोगों को, तो वो कुछ मिसकॉन्सेप्ट्स चल रहे होते हैं, तो उसमें एक क्लैरिफिकेशन करने की ज़रूरत होती है. वो ये है कि फ्रेश ब्लड की जो डेफिनेशन है, दिस इज बेस्ड ऑन लेवल ऑफ 2-3 DPG. इट्स नॉट फ्रॉम द बेसिस ऑफ के जी वो ब्लीड से कितना टाइम में जो है वो उसको हमने ब्लड लगाना है. तो जो 2-3 DPG लेवल है, विच इज रिस्पॉन्सिबल टू कैरी द ऑक्सीजन, ऑफलोड द ऑक्सीजन एट द टिश्यू लेवल, तो उसके लिए 5 days old blood is good enough, जिसमें 70% होता है. अगर 5 days old से ज्यादा ब्लड जो है वो स्टोर्ड है, तो उसमें ये नहीं है कि 2-3 DPG जो है वो बिल्कुल ही गायब हमेशा हो रहेगी और इट विल नॉट बी रिस्टोर्ड. वो ट्रांसफ्यूजन के 12 to 24 आवर्स में रिस्टोर हो जाता है बॉडी के अंदर जाके.
Right.
I will like to add.
Yes, Brigadier.
Brigadier Sahab, फरमाएं.
जी, first of all, Professor Bilkis very elegantly described the clinical aspects, and she touched one very important point that there are some do's and don'ts of management, and one don't, as she discussed, is not to give steroids. And the second and the third and fourth are that, again, as we discussed, not to give platelet transfusions until and unless they are not clinically indicated. Then some people resort to the use of 0.5% saline solution, 0.045, and that is also not indicated. And one very important point is that if the patient is fit enough to take fluids orally, we should not give intravenous fluids. As she said that, that fluid is going into the third space, and this causes more harm than good. So if the patient is fit enough to take fluid orally, why should we resort to give intravenous, fluids? And I would very briefly like to add my own personal experience. I was in Lahore in 2016 until 2019, and I was the station health officer who is also in charge of, to prevent the spread of various diseases, which included dengue fever. And I would like to add that during my tenure, 2017 and 18, there was not one single case of diagnosed confirmed dengue fever in the Lahore cantonment. And the thing which I was that attribute the success was that you have to eliminate the larva of the mosquito. If you want to control dengue, in my personal experience, we tried our level best to build teams who could identify the larvae, and we sort of made it our mandate that in the cantonment area we are going to get rid of that larva of the malarial larvae. And there is one drug, chemical drug, that is goes by the name of Temifos. It is they comprise of small black granules, And what we did was we used to send larvae detection teams daily out into the cantonment. They were trained to identify the larvae, and wherever the larvae were found, they used to put these chemical grains. And believe me, in those 2 years in which I was there, we didn't have a single case of dengue fever. And I think if this perspective regarding prevention of dengue in Lahore specifically, if you build trained manpower force who can identify the larvae and use these chemicals, I think we can to a certain extent prevent the spread of this dengue fever. So as Professor Bilkis is into it, I think she must be knowing this fact. And the second thing is that though I am not an epidemiologist, but I got to know that the fogging thing, what we do is mainly thermal fogging. And this I got to know from a person, epidemiologist of Jaffer Brothers, who manufacture these insecticides. And he told me that this thermal fogging which we resort to, I would in Punjabi they used to say कि जी धुआं कर दो तो मच्छर मर जाता है. That concept is absolutely wrong. Thermal fogging, the vapor size is more than 20 microliters, which I got to know from that person. And he said that if you want to eliminate the vector, that is the mosquito, this size is too big to, stay in the air for a long period of time. And he told me that if you need to get an effective fogging, the particle size of the insecticide should be less than 20 microliters, and that can be achieved by what they call as cold fogging. Cold fogging uses water which is mixed with insecticide. The thermal fogging uses kerosene oil, which is mixed with the insecticide. So if you need to resort to, insecticide spray, which according to WHO guidelines and CDC guidelines is not effective because of mosquito resistance, you need to convert your thermal fogging machines into cold chain fogging machines. Thank you.
Right.
That was very well elaborated, and I think I'll just sir, this is a very, very important point. When there is no definite cure to a disease, the onus of management lies on the shoulder of prevention. And what we have suffered for the last 2 years is that we have suffering from this, a phenomena of a blind spot. I call it a phenomena of a blind spot. Dengue was right there. The mosquito Albopictus as well as Aegypti was flourishing right there in front of us, but it was within our blind spot. We were all focused on COVID, and that is the reason why this very, very important thing has been missed. That is why all of us are suffering today, and this is now too late actually to go for these preventive measures. They should have started when the rains had started, and even prior to that. What we are doing right now, we should have started off there and then. There is no ifs and buts to it. And I think we should learn from experience. And now what I am seeing is the other way around, and I really hope and pray I'm wrong. But now what we are having in the blind spot is COVID. The COVID are now increasing, patients are increasing. Yesterday, I happened to pick my mother from the airport, and it was like nobody was wearing masks at the airport. People were coming all the way from Qatar and Bahrain and what other countries from the Middle East, especially during that time slot, there were flights coming from the Middle East. And I saw people were like, shoulder to shoulder to each other and not wearing masks. So now we are putting COVID in the blind spot, and we are going there. So this is the time when prevention, we should be, doing it at the right time. Prevention is the line of management, actually, when it is dengue. We do not have any treatment as yet. So I fully agree, Dr. Naeem, you touched a very, very important aspect of it, and this is most important, actually.
Thank you, Dr. Naeem, and thank you, Dr. Bilkis. I think Rashid Saab, you have a question. There's another question by
Yes, I wanted actually two questions. One is from the chat box from Wajir Rahman. उसके बाद मेरा अपना भी है. वजीर रहमान ने पूछा है कि how to manage a dengue patient who is on antiplatelets due to previous coronary stent placement. पहले इसका बता दें, मैं अपना बाद में पूछता हूँ. जी.
So since it's a clinical question, so may I answer? Yes. So if a patient, because this is another very common case scenario, whether there is stenting done, whether there has been a bypass, usually patients are on double antiplatelet dual therapy, clopidogrel as well as aspirin. What we need to do is that we need to very, very closely monitor for the bleed, number one. So if the bleed occurs with platelets as high as 120, stop the antiplatelet. If they fall less than 100,000, stop one of the antiplatelets. And if they fall less than 50,000, stop both antiplatelets for the time being. So I hope I made myself clear. And if there is a word bleed at any count, so the patient has NS1 positive, has symptoms, so NS1 is even not there, and the symptoms are suggestive of dengue, which are very, very highly typical: fever, body aches, and especially during these days. And the patients are antiplatelets, and there's, for example, epistaxis or whatever, bleeding from anywhere, trivial bleed bhi ho gayi hai, and the platelets are more than 100,000, stop the antiplatelets. And this has to be, and same is true for the anticoagulants as well. Some patients are
right. जी ब्रिगेडियर नईम साहब, आपसे क्वेश्चन है, ये जो सीबीसी की रीडिंग है उसमें एक होता है एमपीवी मीन प्लेटेड वॉल्यूम, उसके बारे में है कि जनरली जब ज़्यादा प्रोड्यूस हो रहे होते हैं तो उनका साइज़ बड़ा होता है, विच इज़ अ गुड साइन, और वॉल्यूम कम है तो इट मीन्स कि दे आर प्रोबेबली स्टिल इन डिस्ट्रक्शन से एंड समथिंग लाइक दैट. कुछ इस पे कमेंट करेंगे कि इसकी सीबीसी में रीडिंग में और मैनेजमेंट में कुछ इंपॉर्टेंस है कि नहीं है?
उसमें in the case of management of patient who is suffering from dengue and is bleeding, this MPV doesn't carry much of a weightage. It's more of a sort of a theoretical criteria than being of any clinical use. You don't bank upon, or you don't base your management upon whether the MPV is more or less.
राइट. चैट बॉक्स में एक और क्वेश्चन है, आसिफ असलम साहब ने पूछा है. उन्होंने स्पेशली प्रोफेसर बिल्किस से पूछा है कि इज देयर एनी रोल ऑफ आइट्रोम्बोपैग इन डेंगू पेशेंट्स विद क्रिटिकल लो प्लेटलेट्स? ये बाय नेम प्रोफेसर पूछा गया.
Yeah, thank you very much, sir. This is a very intelligently asked question, and something which is being considered, and I'm seeing prescriptions of L-Trombobag being given. L-Trombobag is platelet-derived growth factor, and it is given to stimulate the production of platelets in the bone marrow. Please remember, the platelets are going to come up on their own. So there is no need to give L-Trombobag as per recommendations to this date. Studies are being carried on it, and but as yet it has not been approved by any authority. So we very commonly see, especially in the private setup, the use of L-Trombobag. It's not recommended as yet. Maybe in time it changes, the recommendations add them up, because basically it's to stimulate the bone marrow. But till now, what they say is that the bone marrow will eventually wake up. As soon as the viremia goes down, the bone marrow wakes up. As the virus is no longer in the system, the platelets would go up due to revival of the bone marrow, due to eventual decrease in the antibodies.
and with the repair of the endothelium if it has occurred in the leaky phase and the consumptive coagulopathy which I talked about. So that is why the platelet, do not worry. The target of your therapy is not to increase the platelet counts. I'll repeat, not to increase the platelet counts. So very valid question. But researchers have been going on it, and let's see how they go about it. I don't think that increasing platelets has proven to shorten the duration of illness or the progression of the disease into the leaky phase. So, will L-Thrombobag contribute in it? Only time would tell. But till now, it has not been approved.
Thank you so much, Professor Bilki Saiba. Qazi Wasik Sahib, you're very much here. I would like you to unmute yourself because you will give the vote of thanks. There's Professor Bilkis here who's giving us excellent know-how about dengue. And I'm very, very indebted to Brigadier Naeem Saab. He's the Commandant AFIP, and Professor Nuzhar Saiba, who was the previous Commandant AFIP. So I want to thank all three of them. And on behalf of the PMA, I give the floor to Qazi Wasik Saab, who is our Treasurer PMA, and he is the Acting President SIMAO, which is a confederation of the Oceanic Asian countries, the different medical associations.
Dr. Salma, just may I correct you? Actually, yeah. Dr. Qazi Wasik is a president-elect. He's not acting. Sorry, he is the president-elect of SIMAO.
Yeah, he is the president-elect. Qazi Wasik Sahib, would you unmute yourself and give the vote of thanks to all these great people here?
Okay, thank you very much, Madam Salma, our PMA president. It was excellent talk by Brigadier Naeem, and then the panelist, Professor Nuzhar, made the points very clear. And of course, as usual, Professor Bilkis, it was good and lovely to listen to your talk and your comments. And from the clinical side, it was wonderful, and we learned a lot. It was very enlightening. All the questions those were asked opened up the topic, and it was very, very nice presentation. And I must congratulate Madam Salma Kundi for keeping up this forum very wide and open. The topics are of real importance for the community, and the prevention side, it was great to know that Brigadier Naeem talked about the sprays and the type of insecticides, and it was good. And I think we should all work and force the governments to take care of the preventive side of dengue. And thank you very much. It was wonderful. And thanks to everybody, all the speakers and the participants who were there. It was lovely. Thank you, Madam Salma. And thank you, everybody.
Thank you so much.
Thank you very much.
And thank you to all the speakers, to Professor Mulazim Saab and all the participants. Allah bless you all. Allah Hafiz ji.
Thank you.
Allah Hafiz ji. Thank you ji. Allah Hafiz.